I would like to welcome all of you and thank you very much for taking the time to participate in this webinar, which I hope will be interesting for anyone who follows in these conference-less times. Most of the areas we will cover stem directly out of published work of our guests during the recent years, with a spin towards continuous objective measurement and more so towards PD Monitor. PD Monitor is a CE-marked Class 2A medical device brought to market by PD Neurotechnology. Sometimes I may use quotes from your publications in order to stimulate discussion. I am sure that the participants in this webinar will be as excited as we are about these topics. And without further ado, I would like to introduce you to our guests in alphabetical order. So we have Angelo Antonini, Professor of Neurology and Head of Parkinson and Movement Disorders Unit at the University of Padua in Italy.
Hello, everyone.
Hello, Angelo. Thank you for being here. Per Odin, a Professor of Neurology at the Lund University, Sweden, and the Head of the Department of Neurology at the Central Hospital in Bremerhaven in Germany.
Not anymore. Not anymore. You to skip Bremerhaven.
No. Sorry, Per. So
only Lund.
Just Lund, therefore.
That's right.
And Heinz Reichmann, Professor and Chairman, Department of Neurology, and Dean of Carl Gustav Karus Faculty of Medicine at the Technical University of Dresden in Germany.
Hello, everyone. Hello, Spiro.
And myself, Spiros Konitsiotis, Professor of Neurology at the University of Ioannina Medical School in Greece and Medical Director of PD Neurotechnology. At this point, I would like to disclose that our three guests have served in PD Neurotechnology's Medical Advisory Board. So, Angelo, Per, and Heinz, it is a true honor to have you with us today, and thank you so much for your participation. We have already discussed in other parts of this webinar the extent to which levodopa has revolutionized Parkinson's treatment. That's why it became the standard of care long time ago. But nowadays, the problem is the management of motor complications resulting for long-term treatment with levodopa. And this is actually a key strategy to sustain good motor status for PD patients. So let's start now with Angelo. And I think in neurology, we say sometimes that time matters, especially in the case of stroke. But I think this is also true in Parkinson's disease. So the question, Angelo, is how do we measure time in Parkinson's disease? And with this, I mean, what is the optimal response time to recognize that motor complications have started to emerge? Is this 1 month, 3 months, 1 year, or more? Which means, how often should someone be screened for a change in his status? Is patient self-reported feedback enough? What do you think?
Well, I think that the time matters in Parkinson. Of course, the time frame is different from a seizure or a stroke. But here it matters in the sense that our appointments usually are scheduled with a long intervals. And, sometimes people come once a year or every 6-9 months. And during this time, they are left alone and there is a little communication with the doctor. So I really think that time matters in the sense that we should be able to provide a more detailed analysis, assessment of the patient journey. I don't think there is a fixed time, because it depends on the patient. Some patients have a more rapid progression and they should be assessed probably every month or two, and others that are more stable. I think when the fluctuations appear, I think a period intervals of 2-3 months, I think generally are on average are okay. But it could also be that if patients have had maybe a medication change in the medication schedule, maybe they are assessed more frequently. So I think we cannot fix exactly an interval, but we should consider the various progression rates. And based on that, we should try to adapt the interval to the patient, which is not the case now, as the interval is given by the waiting list of a specific doctor.
Right. Thank you, Angelo. And a question for Per now. Per, I would like to ask your opinion, and actually everyone's opinion, about a hoarder-like usage of objective measurement versus continuous usage. And in the first case, in the continuous usage, the patient uses the device in his natural home environment. He is performing his daily activities while wearing the sensors, and you can ask him to repeat the measurement and the recording as many times as you feel that it has to be done. While in the hoarder-like approach, the patient is given once in a single use, in a once-over use, the device, and there's no comparison with previous recordings. There's no possibility to do it again after a couple of weeks. So which one do you think will be more helpful and why?
Well, I think main step is doing an objective monitoring at all. I can tell you, by the way, we have just done a study where we have validated the house diary made by the patient to a PD nurse has evaluated, and it proves that the patients are not at all very good on finding their off periods and dyskinesia periods. Only about 60% of the off periods are correctly identified by a patient, and only about 30% of the dyskinesia periods. So I think and here, of course, the automatic monitoring is much better. And the first step is to have objective monitoring at all. Then, of course, a continuous measurement, a more continuous monitoring is even better. It can gives you a base for giving a continuously good control of the patient's status. So if it is possible, continuous monitoring with frequent monitoring is the best solution.
Right. Also, in relation to this, what do you think is more rich in information? The information that you can get from 1 week of recordings compared to, I don't know, to an office visit of, let's say, 1 hour, and I think this is too much. In very few healthcare systems, a patient will stay with his doctor for 1 hour, or to see diaries, which are so subjective and unreliable.
Yes, it's to just have the words from the patient, how he's feeling. I mean, that's the normal situation in the outpatient clinic. We ask, how do you do? And the patient says, well, so and so. Then, of course, having a manual diary of the patient is one step better. But to have an objective monitoring over a week is better. And of course, having repeated monitorings over long term is the probably golden standard.
Right. And again, something related, I will ask Heinz this time. I guess if you have this continuous, objective, and quantitative and very precise information, you may do some changes in medication that are better, more precise, more proactive perhaps. And of course, and perhaps we can guess, I know this is very ambitious, but perhaps on this, could this intervention provide better treatment in the long term? I mean, the patient who is treated in this way may be better in the long term, since he is treated, based on this precise information. So your choices are wiser now, in a way. What do you think, Heinz?
Well, I agree. For instance, the first motor complication, the so-called wearing off, is not reported really early from the patients. It takes a while until they come to us, to the outpatient clinic, and report that there is a problem that we call wearing off. Whereas if you have such a continuous objective measurement, you can see that earlier, and you can approach that with MAO-B inhibition or CMT inhibition or more levodopa doses, or you can use a dopamine agonist, so you can address the problem and increase the quality of life of our patients. So I think it is really useful, even in the early stages of the disease, to detect precisely the personalized problem of a given patient.
Right. Perfect. So let's move on in the same context. Angelo, this is perhaps a question for you. Again, in this personalized patient management context, how useful do you think objective measurement to be in ways of navigating through the effects of treatment modifications in various motor symptoms in the length of time, and also the ability to capture bilaterally the symptoms, including gait, with high precision? Would you say that this will help drive, especially the non-experienced neurologist, in his treatment modifications?
Yes, I think, and I think the next question is they also somehow linked, Spiros, because it's on dyskinesias, because I think we cannot split the two issues, so that the capturing the motor condition of the patient means identifying the time when people have gait difficulties, when they are off, when they have poor mobility, but also when they have too much mobility, like dyskinesias. Now the dyskinesias, and if you don't mind, I would link it up.
Right.
I think it is connected. I think the dyskinesias are not always troublesome. Sometimes dyskinesias are accepted by patients. So there are people who are quite happy sometimes have mild dyskinesias, and others who, when the dyskinesias worsen, instead, then you have peak dose or end of dose or biphasic, then of course the situation is completely different, and then people start complaining. Now, again, this is happening at different moments of the day, and frequently when you see the patient, you only see in the clinic, you only see one snapshot. And I think, having a chart of this kind, which shows you the various condition of the patient throughout the day, it becomes quite important, because this is really an unmet need in the current in the current management of Parkinson. We choose a specific medication sometimes based on a perception of what will be best, but sometimes we prescribe maybe an increase in number of doses of levodopa without realizing that patient already has some dyskinesias, and this may actually worsen. Maybe we should use a CMT inhibitor and reduce the dose of levodopa in that patient because dyskinesias are there already. So I think, the decision of which is the best treatment at that given moment depends a lot also on having like a Holter recording of the motor condition of the person throughout the day, like the plot you are showing here. Right. This might suggest that maybe, in this person, what you have to do is maybe lower some specific doses and maybe add a CMT inhibitor to optimize dopamine efficacy, and that's it. But this is something which is not always obvious when the people come to a visit. So you go maybe for based on your inner ranking. So if you in your mind at first MAO-B, then CMT, maybe in the future we will have adenosine A2A, then you follow that line. It is difficult to adapt it to the need of the patient. It is more in the mind of the doctor sometimes, the choice.
Right. Perfect. Exactly. I mean, do you have the feeling that sometimes they cannot correctly describe dyskinesia over the phone? Sometimes you cannot be sure if they are talking about dyskinesia or perhaps this is tremor, while they try to explain you over the phone what is the problem. And I think you would like to see something like that to make sure that this is dyskinesia or whatever. I don't know if there are any comments from our other guests on this very interesting issue of dyskinesia identification.
Yeah, I think you are completely right. It's very difficult for the patients to describe dyskinesias, and even more difficult, of course, to differentiating different types of dyskinesias. And as you also indicated, the very common problem is that they think that dyskinesias is tremor and the other way around. We actually wanted to include one patient in a study with an advanced therapy, because she said that she had tremor all the day, and when we did some monitoring on her, we found that she had dyskinesias all the day. So
Right.
this is really a big problem. And as I said, when we did the validation of the Hauser diary, we found that dyskinesias are only identified correctly in about 30% of the time among the patients.
Right. Thank you. Yes.
I would also like to add that even in the outpatient clinic, sometimes if you don't the symptomatology, it is not so easy to take the history and draw the right conclusion. So if you would see here a screen like here, you could see maybe after intake of levodopa, there is dyskinesia. So it's a peak dose dyskinesia. You see it before and after, etc. It's a different kind, or you may see dystonia. This will make it much easier to make the right diagnosis and start with the right treatment. So I think in these conditions, my patients are quite sophisticated with respect to tremor. I would say this is not the major problem. But all this kind of dyskinesia and dystonia, that's really difficult for them to express themselves. And so I think an objective measurement as outlined here is extremely helpful.
Right. Thank you, Heinz. And as I mentioned before, well, there is some reason to believe that now with this kind of information based on objective measurement, if we may be able to do a better treatment, and this may have an impact on the potentially postponing the onset of dyskinesia or the severity of dyskinesia, because to an extent this has proven true. I mean, in nowadays we see a significantly less dyskinesia than 20 or 30 years ago, because obviously we treat patients better. We are very modest on our treatment with levodopa. So I guess if we now have better information and we treat them with much more detail, perhaps we will be able to further postpone the onset and severity of levodopa-induced dyskinesia. Of course, this is, completely theoretical, but I have the feeling this could happen. Okay, if there are no comments on this, I think we have a final question for this part, and in order to facilitate the discussion, I just selected this diagram here, and everyone can say his opinion. I think it's from a paper by Angelo and Peter Jenner and Ray Chaduri, and is describes an algorithm for the management of levodopa-induced dyskinesia. And so the question, to summarize what has been said so far, how do you imagine could PD monitor to impact levodopa-induced dyskinesia management? Perhaps start with Angelo.
Well, I would say that I think the easiest would be to reduce off-related dystonia, so the off-related symptoms, because then you see poor mobility, and then you need just to adjust, titrate up maybe the medications. Regarding the other two manifestations, I think it is not always easy to manage dyskinesias. We know that we don't have specific drugs except amantadine, and I think, in my opinion, that when you see, when you are in this state, possibly we should consider advanced therapies already, instead of trying to adjust additionally medications, because the patients are probably better suited for one of the three advanced therapy options that we have.
Right. Is bilaterality useful in levodopa-induced dyskinesia management, since PT monitor can monitor bilateral symptoms? Heinz, what do you think?
Well, I think everybody who deals with Parkinsonian patients know that even dyskinesia can be unilateral. And for that reason, it may not be a good choice to do measurements on the wrong side of the body. And also we have patients that present dyskinesia more in the upper or in the lower extremity. So for these reasons, and also axial dyskinesia is present. So for these reasons, I would say it is mandatory to have a bilateral measurement tool.
Right, thank you. Per, any final comment on this issue of motor complications and dyskinesia management?
No, I can only confirm what my colleagues said, that it is very valuable with this type of monitoring for off situations, but especially for dyskinesias, which are so difficult for the patients to detect themselves.
Right. Okay, thank you, Per. And I think with this, we concluded also part B of our webinar concerning motor complications and levodopa-induced dyskinesia, and how objective monitoring devices like PT monitor are affecting the way we treat Parkinson's disease, and they're very useful in revealing the problem and describing the nature and extent of the problem in time and space. I think I will close this webinar, which actually happened these conference-less times and socially distancing times. So I would like to thank you, our participants, Per Odin and Heinz Reichmann and Angelo Antonini. Thank you very much for sharing your views on this topic and how the whole landscape could be changing, catalyzed, I think, by this pandemic situation. And thank you very much for your kind participation in this webinar, and a big thank you to everyone who has potentially and patiently watched it.